All right, we are live. Today's date, this is May 13th. It's a lucky day, the 13th, 2026. With me today on this live event, the first ever actually, is one of our chosen ones, one of the true licensed certified testosteronologists, Jason Bennett, APRN. Jason Bennett is a board certified psychiatric expert nurse practitioner in the amazing state of New Hampshire. He's been with us. Guys, I had my dream to scale everything that I wanted to do. Not just for these guys, but for everyone. And when I realized that scaling medical care for people on testosterone and steroids is bigger just than one doctor or one nurse practitioner or one clinic. It was bigger than even one specialty. So testosteronology really is a consortium of healthcare practitioners that all work together for the goodness and for the care and the wellness and the care of people on androgens. So let's go head to toe. We're on androgens, what does it affect? They're psychiatric. Come on, guys. This is not the sexy stuff. They're not talking about this. At the TRT clinics with that beautiful man and wife that walk on the beach, like, do they look great in the beach? Sure they do. But are people suffering? Yeah. I mean, it's real. Is testosterone great for suffering and for depression, anxiety? Maybe. We have Jason Bennett. We're starting with the psychiatrist. We have endocrinologists next. We have infectious disease experts. They're all trained to take care of people that are on testosterone and androgens from harm reduction. But we wanted to start with Jason. And I've known Jason for about 2 years now. Jason, please tell us about yourself and what you do. And then we're going to open up today with your talk. And then we're going to open up to questions that are so important about depression and anxiety, because this is your life as an expert. And this guy he's opening for practice. He's on our directory, Testosteronology. He's one of our providers, and he is so good for taking care of people that, again, men with depression, because he's an Army man. This is a true veteran here, guys, and he's going to tell us about that. But he's accessible. Well, I could talk forever. So, Jason, go ahead. Tell us what's going on today.
Yeah, awesome, Dr. L. Thank you very much for having me. Very proud to be in the society, and very proud to be taking care of folks on androgen, anabolics, TRT, to the highest standard. And, practicing psychiatry, usually you are taught this, practice on an island, right? Here up. Well, in the society, we know that's not true. We know we treat the entire patient, and being a nurse practitioner, we have that real push to do things holistically, right? So being a testosteronologist, as an outcropping of internal medicine, getting to learn that side of things, and really now expounding my practice, so I'm doing general psychiatry. I specialize in treatment-resistant depression. I treat fellow veterans. I treat members of public safety, police, fire, EMS, and I also specialize in addictions medicine and weight loss. So it's all tied in together. Wow. The metabolic state is intertwined with the mental state. Right. New England, one of my favorite quotes ever from 1933, New England Journal of Medicine, pretty big publication, right? We like that up here in the Northeast.
Old school.
And 1933, we have known for at least a decade, I'm quoting this direct out of the study, at least a decade, that properly dosed testosterone will ameliorate depression in men, meaning depression will get better. Anxiety will get better. There's the other side to that, to where too much of a good thing might be inducing a little bit of anxiety. So for those of you out there tuning in, thank you, welcome. We're honored to have you. We love taking care of you guys. There's a lot of information online, and yet you chose to come here to see us because we practice medicine. We practice it at the highest standard, and we are here to care for you. And I'm very excited to give a little bit of a talk about, some light pathophysiology, right? Because you speak too much medicalese, you start to fall asleep at a conference, let alone what these poor people got to put up with if we start going too deep into things, and that's not to pick on anybody, but if I can understand it, then, hey, we're all on the same page here. You know what I mean? So anxiety and testosterone. Does testosterone cause anxiety? I don't know. Some people might have said that, back in DSM-3, back in the early 1990s, when they said, it might induce a little bit of mania, it might induce, a little bit of anxiety, it might induce a little bit of depression. Okay, sure. Yeah. If you abuse it and then come off of it cold turkey and you don't do post-psychotherapy, you're absolutely having a hormone crash. No doubt about it. You mess around with some of the newer, more popular compounds, even though they've been around for a little while, back when it was parabolin, like, trenbolone. Yeah, you're going to offset dopamine, right? We'll touch on that in a little bit. But what I really want to talk about is I want to talk about the two main players in neurotransmitters, right? Think of these guys as your primaries, right? Your 1 and 2. And that's glutamate and GABA. GABA is your chill out, rest, relax. Glutamate is get up, get going, move, right? So in psychiatry, we can kind of get wrapped around the axle a little bit about, everybody heard about serotonin. Serotonin this, serotonin that, serotonin reuptake inhibitors, very popular, right? So for every one bit of serotonin, in terms of serotonin modulator you got in your brain, you have 40 glutaminergic. So let's go to source code, right? Because glutamate and GABA do this like a seesaw. They balance. And you know what directly affects glutamate? Is how much GABA comes up, glutamate then has to come up. You know what directly affects GABA? How much glutamate comes up, and then how much GABA needs to balance it. We want an equal kind of buoyant scale. Think a seagull sitting on top of a buoy in the middle of the ocean. It wants to stay buoyant. If it dunks too low, seagull gets wet, he gets mad, he flies away. If it just sits up there too high, then, nobody really pays attention to that either, right? And the buoy kind of becomes a mess. So we want to have what's called homeostasis is the medical term for it, right? We want to keep things nice and even. So that's what these two neurotransmitters do. And testosterone, more specifically, the byproduct of testosterone, dihydrogenase testosterone, or DHT, right? We talk funny where I grew up. I grew up in Boston. So if you guys can't understand me out there in the audience, just say, hey, slow down there, wacko, and, pronounce your words correctly. And I'll do what I can, okay? So DHT and GABA have a relationship in the central nervous system, meaning they balance each other out. Just the right amount of DHT, just the right amount of GABA, right? It's kind of like Goldilocks and the Three Bears. One porridge is too hot, too much DHT, you're going to desensitize things you don't want desensitized, right? Too little DHT, you're going to be anxious, you're not going to feel good. Just the right amount, you're good to go. And, we all know about DHT derivatives, sinazanol or Winstrol, it used to be called, right? Or oxandrolone, Anavar, kind of things that are a little more popular, but all testosterone, whether it's cypionate, enanthate, propionate, all these different esters, sustanon 250, all 4 of them, they eventually convert to DHT. So what is DHT doing? DHT is directly impacting, GABA directly impacts your ability to chill, relax. Now, some folks might have had a little bit of a mismatch to begin with, right? So when you look at the umbrella of anxiety, so-called disorders, right? You have something called body dysmorphia. We hear a lot about lay people saying, well, anybody that's in the gym has body dysmorphia. Well, I don't know about that, but, because we all kind of have a drive to be healthy, to look better, right? Guys our age, we grew up with, good male role models who were all in shape, guys who all worked out, right? And for some guys, that goes to the extreme where it's like, oh my God, I'm never big enough, right? Or bigorexia is another term that's thrown around in the gyms a lot, right? So these can be real things, but what it comes down to is it's not enough GABA. You're having too much anxiety. You're having almost too much glutamate, right? And glutamate's a good thing. It's what makes you move, what makes you go. But when the academic studies, it's, we're medical professionals. We like to look at, gold standard. Unfortunately, a lot of the gold standard data, even though, I know you're working on this, directly with the survey to try to get real world results, real world people talking about real world experience, right? Because the data we have is in lab rats in a lot of these controlled studies because it's convenient. But, providers like you and I, we're concerned about gym rats. What's in the real world? What are our people doing, right? So a lot of this data was, it's small cohorts, meaning it's a small participation. I think the biggest one I found when I did a little bit of a lit review before today, or literature review, to take a look at published data, the biggest cohort I could find was like 52. So that's not a lot of power, but we also know anecdotally for decades. I think between the two of us, we're probably, I don't know, not to make ourselves old, but probably 70 plus years of gym experience at this point between the two of us.
Oh yeah.
So we know this culture. We know that there are guys and girls out there that do have some body dysmorphia, and some of that is just a drive of, hey, I'm not happy where I'm at. I don't like the way the stone looks now. Okay, well, keep sculpting it. Put your time in the weight room. Put your time in the bedroom for sleep. Put your time in the dining room, eating properly, right? But sometimes that's not enough. Maybe there is a little bit of a chemical imbalance. So people kind of looked at that. And when I looked at the data from going back to 2002, what it showed mostly was acute withdrawal, right? Of, no post-psychotherapy, just a crash. Now, thankfully, not a lot of people do that anymore. And, in the medical community, we still have some providers that will, say, look at a hemoglobin hematocrit that's slightly elevated through androgen-induced erythrocytosis. We'll call it the appropriate thing, but they'll call it polycythemia because they don't know any better. And they'll pull people cold turkey off of testosterone, even though there's an FDA black box warning that says don't do it because it will induce depression. Not it may. I'll call it what it is. It will induce depression. You can't go from feeling great, from recovering, from eating well, sleeping well, increased libido, all the good things that testosterone does and, anabolics do when used appropriately under the care of a provider. You get this great benefit, but if you just stop that, you're getting an absolute crash because you're taking away all that DHT. Your estradiol goes high, which, you want estradiol, you don't want to crush it, which we could definitely talk about that and how that balances mood as well in just a bit. But, we really want to stay away from the extreme polar ends. We don't want, guys and girls taking a gram a week of test. It's too much. If you're a professional, you're weighing your risks out, risk benefit. Hey, we get it. We're here for you. We want to take care of you because we want to actually pull your blood work. We want to show you what's going on and we want to treat you. We don't want you to end up with coronary artery disease. We don't want you to end up with renal failure. I don't want you to end up with acute depression, when you come off of excessive trenbolone use. I want to really reiterate to folks that if you are having some anxiety and you are having some depression, that the greatest anxiolytic or antidepressant, right, what makes you feel better, the greatest one that I have in my arsenal for my prescription pad is hard exercise done safely, preferably in a group setting or with a partner. You know what I mean? How great has it been, 3 or 4 guys in the gym, all pushing each other, all hitting PRs. You feel great. You feel great for hours afterwards because, not only does your dopamine rise, that's your drive, that's your get going, that's your run toward pleasure, run away from pain, right? But your glutamate goes up because you're active, and then your GABA comes right up with it. And when that's properly balanced, what I could see in the review of the data is that, that's really where things are at. Now, do I need to sit and explain the 90-point system checklist review? No, I'll put everybody to sleep if I do that. But the long and short of that is where is your mood throughout the day? Do you have mood swings? Are you fluctuating, right? Are you having, increased blood pressure because your blood pressure is out of control because you're taking too much of an androgen? Is your blood pressure out of control because maybe you were genetically predetermined to it? Are you not drinking enough water? Is your creatinine, elevated? Are you not functioning optimally? Are you drinking alcohol in addition to taking anabolics, which, you're really killing the return on your investment there, but we all know guys do it. So we want to talk about this harm reduction, right? We want to talk about the health of the HPA axis or hypothalamic pituitary adrenal axis, right? So you want to have a balance. The body wants to have a balance with that. And we're producing testosterone when we're young. That's one of the things that, helps us to grow, right? As men, it's our primary sex hormone. And, it sits in a balance with estradiol, roughly 1 to 10, depending on who you read for a ratio, right? And when that starts to become out of balance, guys that have, like, let's say metabolic syndrome, right? They have diabetes, they have high blood pressure, dyslipidemia, bad cholesterol, right? Their estradiol goes up, their testosterone comes down, and it's multifactorial. We have to take a look at it. We can't just say, well, hey, let's just give them 100 milligrams of Test-Sip and we'll call it even. And while we're at it, we'll give them an AI just for the hell of it. We don't do it that way, right? We look at everything and we kind of run things in a balance. Well, the mental health aspect is in the same way. We have to look at the root cause of the anxiety. Why do you feel anxious? What is, actually going on? And for men, I tell, my patients, the hardest step you took was the step to come and see me in the first place. Because we'll drive around in circles for 4 hours as a guy before we ever pull over and ask for directions, right? Thank God for GPSs and the smartphones. Otherwise, we'd still be doing that. You know what I mean? So we don't ask for help, right? Whether that's a pride thing or what. And a lot of people will look at it like, oh, well, if you ask for help mental health wise, it's weakness. Okay. Well, if you fell down the stairs and broke your ankle, would you just tighten up your shoe and go to work and say, oh, I'll walk it off? With your legs sitting there doing this, people look at you like,
but do you want let's talk about this. So and we're going to open up for questions, guys. So let's open up again. We'd like to get real mental health questions because we have an expert here. And so come on, again, go on the stage here, go to testosteronology.com/stage. And then you just need to get in there and you could ask questions. So let me ask Mark, our tech guy, can we have them on visibly, Mark, or can we just,
yes.
Okay.
If they choose, or they can just be voice.
You can do voice or come on visually. So we'd like to have, if you want to come on visually again. So, but Jason's here and I want to really make this so important and impressive for people to understand. Everyone has something, I've had depression, some severe depression in my life. Things happen. People have chemical imbalances where and if you're born that way, it's tough when you're a child and maybe you've been having some abuse, unfortunately, and it's just can't sweep it under the rug. And people are tough though. They get through these things and they cope with it. Right. But they have suffer and it will manifest. Right. So, and it's through life and we all have it. So when you look at this wellness life online, there's so much information and some is very, very good, but a lot of it's not good. And they're just selling, let's face it, they're selling bullshit. They're trying to sell their pills and their peptides. And I'm not against this guy is a big peptide guy. He loves peptides and he's a young guy. I'm the older guy. And I'm like I'm a testosterone and steroid guy back from the day, right? Go harm reduction. Don't take steroids. But I've been around for a long time. He's younger than me. And, and he's stronger than me, but that's okay. I have a good ego. See, my ego is I have an ego problem right now. Right. So that's how, but we're men. And I just think I love to say this. We're not the brightest bulbs in the tree. We don't ask for help. Come on, guys. Men take testosterone and steroids, as he was elucidating with the it's beyond dopamine and serotonin and this GABA. And I don't go there, guys. I work from the chin down. Heart, liver. It's much easier down here. He's got to work from the chin up. This is tough. If we have so many meetings and there's any healthcare providers out here that wanted to come to join this team, you think you have what it takes to be on the directory like this guy right here and 26 other ones. And we have about 60 under training all over the world. It's the highest standard of care. You got what it takes? Jump on Testosteronology Society and see if you can kick the tires, come in as an associate. Maybe you want to come in as a real potential training testosteronologist where this guy started 2 years ago. So essentially, let's talk about testosterone. And I want to, because I see it in my life, but he's a professional with anxiety. So guys, so many guys take testosterone, Jason, and then they worry about their estrogen and my anxiety. Come on, dude. Tell us about estrogen hold on.
Yeah.
Testosterone, estrogen, aromatization, and anxiety.
Okay. So, testosterone gets converted to DHT through your 5-alpha reductase enzyme, right? So that's a good natural process. When that happens in excess, what you have excessive aromatization of estrogen, or E2 is how it shows up. Or if you run it in one of our panels, it's ultra sensitive estradiol, but you want that roughly in a ratio of somewhere around 1 to 10, or as one of our other testos, John out in Colorado would put, I don't care how high your number goes, as long as you're not having symptoms, I want it nice and high. So guys, here's what estradiol does do. Okay, estradiol is good for your mental health. It helps keep depression at bay. It helps keep things in balance. It's great for your libido. Okay, it's going to help you, get and maintain erections. It's great for your joint and ligament health and protection, and it's cardiovascularly. It is protective.
Right.
You don't want your level going, let's say, arbitrarily too far below, I don't know, 35, maybe 30 on the low end. But if you have an estradiol of, let's say, 45, and you're asymptomatic, you're not developing any nipple tenderness, you're not anywhere near gynecomastia, which some folks, they just are genetically, right? But if none of those things are going on, you want that number to be high because it's in a balance. You want that to work for you. You want everything to be optimized, right? You don't just, I want my testosterone level to be 5,000. Well, okay, great. But if you're having symptoms when you're at 5,000 because you're having anxiety because your estradiol is now 280, that's probably a problem. But then, I'll just crush it with an aromatase.
But they blame it on, it's amazing that they blame it on, it's just a funny conundrum, guys, after seeing this for decades. And now these guys are here and there's so much testosterone, which is awesome. And America has TRT clinics, and now we see that all over the world, and we're helping develop it all over the world. So shout out to Canada, shout out to South Africa, shout out to South America, guys in Australia, over in the UK. Those are really the growth markets for us. And that's where people are, right? So you take testosterone, you convert to estrogen. Now we're moving where if your healthcare provider or guru or yourself or your bro or your coach says, hey, dude, take the nostrozole and block it, boom, boom, boom. Hold on, guys. So I look at my estrogen, it's super elevated. Is that right after the injection? So is it the peak? Is it the nadir? It's going to be very dynamic. Don't treat that number. But like Jason said, we've done a lot of research on this, right? We've looked at this and we talk at these meetings, like real research. And they're not randomized clinical trials, guys, but they're the best there is with meta-analysis, observational. And of course, most of the peptides they're just citing mammal rodent research. That seems to be good enough for peptide. So it's like, we know anecdotally when you look at guys, remember back in the day when I started 20, 25 years ago, guys are coming in on test and D-ball. That's estrogenic. They're on 250 or 5. They didn't do that much back then. Doc, I'm on 250, sussing on 250, maybe 1 or 2 shots a week, 500. I'm taking like D-ball, anadrol, maybe anadrol, A-bombs, maybe 1 or 2, 1 a day, maybe sometimes 2 or 3, right? Strong guys, it would scare me with liver enzymes. And then I was looking at the estrogen. This is 20 years ago. And I'm going, holy moly. It was off the chart. I was an internist, who was on some steroids out of residency. I'm like, I didn't learn this in med school. How do you feel? Holy shit, doc, I feel great. I'm like, whoa, hold on, cowboy. How's your sex drive? One guy said, doc, I could fuck your desk. I said, sir, leave my desk alone. You leave the desk alone. And I said, sir, you keep doing that funny stuff, you're out of here. I'm just joking, doc. But I go, wait a minute. Based on my calculation, because the anti-aging guys were around then and they were crushing estrogen. They were blocking estrogen. And I'm like, based on the calculations, you shouldn't be able to have any sex with any desks or women or yourself. And doesn't make sense. So it's not the estrogen, but can it be estrogenicity and your moodiness and the complexities of your brain with conversions to DHT? Guys, hit an end button. So that's why we want guys to not hop on testosterone if you don't need it. Don't, especially young guys. But if you need it, you need the top care from someone like this. That's really not some anti-aging. Again, I'm sorry about that, but it just can't be. That's got to be testosterone. Now, let's get some questions. Mark, you want to tee a question up? We got guys waiting for questions now.
We got Lou.
Lou, what's going on, Lou? Why don't you? There's Jason. What do we got, Lou?
Can you guys hear me and see me okay or no?
Oh, yeah, perfectly.
Yeah. Oh, yeah.
Awesome, guys. Well, hey, thank you so much for your time, Doc. I've been a fan for a long time listening to your stuff. Really good. You got me on the 1010, the 10 Zetia, the 10 rosuvastatin, LDL's like 50, right? I was over 110, 120 for a while. And you hear all the fear mongering about the statins and all that shit. And, I find my doctor's fine. My doctor lives too. And he's like, dude, you're going to have a heart attack. You need to get that shit under control. Right. So I got all that. I got the, cardiovascular's good. A1C's like a 4.8. All that stuff's really good, man. So it's really on target. I'm glad you brought Jason on. Jason, I got a question for you, man.
Yeah.
On the mental health space, I asked Doc via chat earlier, and he said save it for tonight. But for a lot of us guys that are kind of type A drivers, we like to maintain our total test at around 1,000.
Okay.
Free test 25 to 30, right? It's hard to shut down at night sometimes, right? There's a lot of guys talking about using low dose SSRIs to really up the allopregnanolone, right? And the BDNF. How do you feel about taking like a small dose of Lexapro just to take that edge off and really kind of balance yourself out a little bit more?
Sure.
Without feeling your dick, obviously, right?
Yeah. No, for sure. So in terms of so-called selective serotonin reuptake inhibitors, and I say that because we can say they're selective all we want, but the reality is 90% of serotonin receptors are actually in your gut, right? Only 10% exist in the brain. In terms of the one that are more centrally acting or more affected the central nervous system, Lexapro is top of the list. Lexapro or fluvoxamine or Fluvox, it was the old trade name for it, are about the only two that I really tend to endorse because they tend to be weight neutral. They tend to have the least amount of sexual side effects. As opposed to, I'll pick on one because you mentioned BDNF. Zoloft or sertraline has been demonstrated to specifically retard BDNF production in the pancreas, in the beta cells. So you retard BDNF, right? Brain-derived neuroprotective factor, right? You retard that in the beta cells. Now, granted, there's another testo who's an endo expert, right? She can give you a much better pathophys picture on this, but I'll give you the Reader's Digest version. You start messing with too high of a dose of that, you kill too much BDNF in the pancreas, you retard the effect of the beta cells, you're going to get insulin resistance. You get insulin resistance in a man, you're going to get truncal obesity. You get truncal obesity, contributing to metabolic syndrome. That directly affects cholesterol. You had talked about having some dyslipidemia, right? It also negatively affects blood pressure. It will negatively affect your overall cardiogenic metabolic health, and you start to have declining vascular health, right? So the basic rule and really anything in neurotransmission is what goes up has to come back down, right? So glutamate and GABA balance each other, right? Glutamate directly stimulates BDNF better than anything. So you know what stimulates BDNF better than anything? Hard, vigorous exercise, because that directly increases glutamate. Now, in terms of taking the edge off for sleep, there's unique serotonin multimodals, one of them being Remron used to be the trade name of it. Mirtazapine is the generic.
Yeah. Mm-hmm.
So mirtazapine is a paradoxical drug, right? You get a lot more H1 or histamine effect.
Histamine blocking at lower doses, yeah.
Yes. So I prescribe, and again, just so we're all clear for everybody listening, right? I am a nurse practitioner. I'm not your nurse practitioner. So this is theoretical. If you were under my care and I was using mirtazapine or Remron, I would use it at 7.5. I use it at a very low dose because it works paradoxically. Now, will it affect serotonin? Yes, it does. Very uniquely, in fact. But specifically, some of the SSRIs, they tend to, over time, they work a little bit too well, meaning they blunt your ability to have any kind of reaction, right? So not that they induce dysthymia, because that's not true. So dysthymia, think of the best way I could explain that was, remember Eeyore from Winnie the Pooh? Mm-hmm. Remember that, kind of, thanks for noticing me. Yeah. Today's sunny. Yeah. Today's rainy. That's dysthymia, right? You're just kind of always at a baseline, just bummed out, right? You give a guy a lottery ticket and he gets mad about having to drive to the store to cash it in, right? Yeah. That's dysthymia, right? So, SSRIs can kind of cause a little bit of cognitive blunting to the point to where people, they don't really feel anything, and it's debatable whether or not specifically the serotonergic effect or perhaps a little bit of what we call a sigma-1 effect, which, is not real wide studied in SSRIs, but if you look at some other drugs, some of the newer ones like Auvelity, which Auvelity is actually two old drugs. It's dextromethorphan and Wellbutrin put together. But it has strong sigma-1 effect, but one of the potential downsides of that is anorgasmia, or you can't finish, right? Yeah. So SSRIs can lead to erectile dysfunction. You need, an agent like, a vasodilator like sildenafil, tadalafil, stuff like that to, get things to function.
I mean, everybody I know is on daily tadalafil anyways, right? Like that's old news, man. Everybody's taking 5 to 10 milligrams.
So many guys are using sertraline, wink, wink, and because you could be a porn star if you have premature ejaculation.
Yep.
Well, if you might as well throw in some cabergoline as well, so you don't have a refractory period.
Unbelievable.
Either, right?
Unbelievable. Well, that's old school.
Yeah, so cabergoline's, that's a great drug, right? Or K-bar as it's called, right? Which I personally, being a vet, I think it's hilarious. We call a drug K-bar, but to me that's a knife. But when you look at the effect of what cabergoline does in terms of dropping prolactin, you're getting elevated prolactin because you're having elevated dopamine, specifically in the D2 pathway. Now, whether that's afferent or efferent, going or coming, it's in the ventral tegmental area, which you can look that up later for extra credit, or we say in first aid mnemonic, where the trouble arises, VTA, right? You say it with a thick German accent, so you remember it. Too much dopamine, think Parkinson's. Not enough dopamine, you just ain't moving, right? You got nothing. So in psychiatry, there's, really 3 dopamine pathways that we kind of understand, right? The fourth one, we just discovered, years ago back when I was an undergrad. It's called your willpower center. We don't know much about it other than the more you use it, the bigger it grows. And that's from a lot of postmortem study and speculation. D3 is, kind of a weight neutral pathway. D2, think your old school neuroleptics like haloperidol, thorazine, things like that. Those are D2s, right? So too much D2 or too much acetylcholine, muscarinic, or histaminergic, right? Or too much anti-ham. Eat too much ham at Thanksgiving, you're going to get fat, right? Same thing with some of these drugs. If you have too much of stimulation in this, you're going to get problems, right? You raise prolactin, what are you going to get? You're going to get development of gynecomastia. You might even, have some, leaking nipples. I've seen that actually.
Galactorrhea.
Yeah, right. Galactorrhea. Yes,
it's crazy to see. Crazy to see.
It is, and when
leaking tits and the churn on.
Yeah. Oh, it's terrible. And so you're trying to balance this stuff out. But here's the thing. My personal view on psychotropics or really any medication, right? Let's use the least amount. They got to work, and let's use them for the shortest amount of time possible. So my favorite thing to do is deprescribe, because I want you on synergistic compounds, right? Or to put it back in gym terms, I could give you 100 of tesipinate theoretically, and I could give you 100 of nandrolone decanoate and give you a better result than taking 200 of either of those compounds by themselves, right? We know that they're synergistic for it's a class 1, class 2 steroid combo. We've known that, for years, right? Not to put Doc on the spot, but we've known that since Anabolics 2. We're at what? Anabolics 11 was the last one that you helped, right?
Right.
You know what I mean? So we're really advancing. Guys are using, sildenafil, tadalafil, for just vascular health. But it's like, okay, kind of like staying on a DHT derivative, right? Go ahead and run oxandrolone for greater than 60 days. You won't have to worry. You don't want to have to worry about coming too quickly because you're going to last forever.
Right. Some guys. So this is unbelievable. I tell you, I know we got some guys waiting. Lou, good to see you, brother.
Thank you so much. Hey, Doc, real quick, appreciate you guys. Before you get off today, can you touch on pregnenolone and DHEA before you guys get off? Because I know a lot of guys are all confused about filling all the pathways once you cut the nuts off.
Let me tell you what I think about that. So when I think about the adrenal axis, this is adrenal stuff. Those are weak. I'm kind of a foo-foo guy now, and I do apologize. You look for you got testosterone, you got the balls. And then we have testosterone esters, goodbye balls, and you go right to the brain, you go right to the, I mean, it's just what it is, right? I just don't want to have a heart attack and keep the kidneys good. He's good for the brain. I got from the brain down. So, and we got other doctors here, right? Nurse practitioners. Thank you. When it comes, guys, when it comes to these goddamn weak secondary, and I call them adrenal androgens, you got to give me a fucking break. You got to give me a break. I'm a data guy. Okay. Now I know you progesterone, you could take it to sleep like a little baby and this and that. I get it. But there's side effects. There's hypertensive side effects. There's going to be I learned it from these guys. Again, I don't work alone. I work with now all these guys. We talk and talk and talk. We look at data. So I think this, dude, you're on testosterone. You're on testosterone. What are you doing with fertility if you're a young guy with that hypothalamus pituitary gonadal axis? What do we do? Are we doing HCG? Are we doing a little clomiphene with it? Which I know they're doing that now too. Are you just waiting to maybe you can just come off and just blast HCG? Dude, look at the hair. Okay, so you're trying to make me feel bad. I know you're trying to make it's okay. See my ego kicking in again. I need something for the ego. Yeah. So psychiatric. The reality is when you're on testosterone, a good dose, and you got your ABCDs, and don't crush the estrogen, work around it in micro dose. We have sub Q, we have breaking it up to, maybe Monday, Wednesday, and Friday. If you really want to do this and look at the micro dosing and understanding using the lowest effective dose, when it comes to adding, dude, dihydroepiandrosterone and pregnenolone, I've been doing this for 25 years. There's really no one. There's like maybe I have my nemesis. What's a guy in California? They call him my nemesis. He's a good doctor. He's a good guy, but it's like he doesn't bench 500 pounds. Oh, I didn't say that. Okay, but it's like hold on. But he's probably the same age. I don't believe, and I think he's going to support me. These things are pissing in the wind.
Right.
I'm telling you. I've been doing this for so long. I'm the guy, Doc, can I add some DHEA? I'm like, go ahead. I don't know. It's just pissing in the way. If you're a woman or if you're not on any androgens, it has some effects. But if you're on androgens, you're on a testicular androgen and you're giving it to your brain. Come on, guy. You have too much time in your hands. You know me. I'm just having fun. You guys have too much time in your hands. And go back to the low-hanging fruit. A, B, C, D. Don't have a heart attack. Feel great and kill it and focus on your ABCDs. I'm just so sorry. No, who's going to come into the ring and argue me with data that adding these weak adrenal androgens, I'm not saying for someone who's not on them or a woman. I'm saying because it moves the needle a little bit, right? Mm-hmm. They're adrenal androgens and they're metabolic byproducts. I'm done. So, but that's why you're here. That's why you trust me, because I'm going to give you the straight talk. I'm not saying it's bullshit. It's negligible. You're on testosterone, not to mention some other agents and peptides. Woo! How do you feel, dude? And if you don't feel good, you got to go to Jason, because I'm telling you, dude. I'm telling you guys. Everyone has stuff going on. It's a complicated world. And the anxiety and the depression is super, super complicated. And what you guys talked about with adding those neurotropics, right? Now, there are some of these billionaire guys, right? I can't stand some of them. I've had all these prima donnas. Like, they're doing modafinil. They're doing smart drugs. They're doing, I make them laugh. I have these guys. Okay. They're baby sized. Okay. They're like, Doc, you're crazy with this. They want to make money. They want to be in Mensa. You know what Mensa is? Look up Mensa. You're too young. Okay.
No, I know what Mensa is.
Which is fucking crazy, which is kind of funny. And then their penises must be small. I didn't say that. Okay. So they want to make money, tons of money, which I get. I understand. I love it. Power. They don't give a shit about. They want to get girls or guys or both, whatever. P. Diddy stuff. And then at the end of the day, they just want to crush shit in the boardroom and be powerful. And I get that. And they want the brain to never go. Now they're understanding PCSK9s, sodium glucose cotransporters, and they're understanding some of the stuff with Jason, because these are guys that when they're in the boardroom, they're going to be like boom, 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 but they have depression and anxiety. They're not normal, right? Like I'm not, right? I'm on the spectrum. So it's like, it is what it is. But this is where, when it comes down to it, I want to give you guys the truth. And we're talking about these little pissy DHE. I'm sorry. It's there's no data. It doesn't move the needle. We're talking guys that really have medical issues, and you're on testosterone. All right. But dude, good to see you. And
Love you guys. Thank you so much. Jason, you do telemedicine?
Yes, I do. Yep, absolutely.
Thanks, guys. Appreciate you.
Awesome, Lou.
All right,
Let's get the next victim. We call him victim. What do we call them? Next participant. It's going to be. I knew it was going to be a great night. Go ahead, Jason.
Went on Prestige. Okay, good.
But hold on. Let's read it for everyone. Can we put it back up, Mark? I had to. Go ahead, Jason. Go ahead, please.
So I had some anxiety.
Right.
And I went on Prestige Med, and it helped. Okay. So, and again, I'll answer this. Is 200 milligrams a week too large of a dose? Okay. So, same guy. Yep. Okay. So to answer this person's inquiry, in theory, if I had a patient on Prestige, which I do prescribe Prestige. It's a so-called serotonin noradrenaline reuptake inhibitor. It's a concentrated version of another one called Effexor, or to use the generics, venlafaxine is Effexor, desvenlafaxine is Prestige. So it's the S-nomer of the drug. So think of docking a boat into a boat dock. You have the bumpers on the side of the boat for a reason, because they bump, they crash. But if you put the wrong size boat and the wrong size dock, you're taking up too much space and nobody else can park, right? So now steer it very precisely and have it fit like a lock and a key. And that's what the S-nomer drugs do, right? So the previous guy, Lou, he had talked about Lexapro or S-citalopram. That's the S-nomer of citalopram or Celexa. So it's basically a more concentrated version of the drug. So it's easy in, easy out. Is 200 milligrams at a week a lot? No, because you can do 100 milligrams a day is the relative top end of that. Now in psychiatry, we don't have upper limit per se, as long as the clinical efficacy, we can keep going. But with drugs that affect specifically noradrenaline and dopamine, which this does, affect serotonin or at the 1A part of the serotonin receptor, which is a little more complex probably than what we should dive into. But think of serotonin like a ring, and there's 8 docks around it, and then out of that 8 docks, there's an A, B, C, and a D in some of them, and you can go in there and you can park your boat, right? And what this drug is doing is it's essentially it helps to ameliorate anxiety. The higher in the dose that you go on it, the more noradrenaline effect that you get compared to the dopaminergic effect, right? So you can top end of that drug. In my clinical experience, what I've seen, the top end is probably about 300 or 400 milligrams per day. So, do I think 200 milligrams in a week is a lot? No, not at all. But if you're using the least amount of it and you're getting good clinical effect, here's what I would say anecdotally to that. If you had a headache and I said, let's take an aspirin, and I gave you an aspirin and 325 worked, well, why would I say take 2? For what reason? Why give you 500, make the body process 500 milligrams when 325 milligrams works? That's kind of the same thing with these drugs too.
Is this guy, I kind of was off on the side here. Is he taking is this gentleman taking it like PRN or like what?
That's a great question. So do I think Prestige would work PRN? Absolutely not. No, I think it takes time to build up in your system.
But sir, can you tell us? Can you tell us, like, sir, what do you? I use 200 milligrams of test. He's using 200 milligrams of testosterone a week. But go back to the one before. Okay. Go back to the one before. So he's. Yeah, so that did make sense. So he's on testosterone.
Okay, so he's using Prestige and testosterone cypionate. So my concern with using any drug that manipulates noradrenaline and dopamine is the downstream potential of hypertension. Now, can you use testosterone cypionate with someone with pre-existing hypertension? Absolutely, all day long. You have to control the hypertension. Now, there's many ways to do that, right? And that a lot of it will depend on, quite frankly, your prescriber's comfort level, right? Because we all learn different meds. We're all comfortable with them.
Right.
I think drugs like, telmisartan are absolutely wonderful. The angioretention, the ARBs. I think they're great. I also have a preference towards lisinopril, the ACE inhibitors. I don't tend to use the calcium channel blockers like the amlodipines. I don't like higher dosing in the beta blockers because of the negative effects. But you want to find the one that works well for the person, because if you're controlling the blood pressure and you need to be on testosterone replacement with testosterone cypionate, you're going to have better metabolic health. You have better metabolic health with testosterone that's in range. You're then going to have less anxiety. You're going to have less depression because, you're going to have less insulin resistance. You're going to make greater use of, essentially your time, and your blood pressure is going to come down. If you go on testosterone cypionate, you get back into shape, you drop 20 pounds, your blood pressure is going to, be back in a normal range relatively quickly. So you might need to even lower your dose of your blood pressure medicine.
Or does Prestique cause hyper? So Prestique?
It can. Yes,
Okay.
absolutely.
So that's
yes,
one of the
it definitely can.
So it's like, and I know some of these drugs, right? But I do work from the chin down, guys.
Yep.
But it's like these antidepressants, guys. This is a whole like I have my GLPs, my GIPs,
Yep.
right? Everyone has those. I have the sodium glucose coach. I have my Jardiance, right? And
Oh, yeah.
I have my Repatha. Guys, this is on. So, but this guy has he has his neurotropic drugs. I'm telling you,
Yes.
it is just and I worked as a primary care doctor, and I worked in nursing homes where I had to give these to little old ladies and stuff, and it was I'm a geriatric psychiatrist today. I was nervous. I mean, I was very careful, and I just can't consult geri psych everywhere, right? They're not out there, so I had to learn it, and I was humble for all these drugs and Seroquel and just for people that have dementia and they're aggressive, just to really sedate them, and then the family sees it. And okay, so when you guys you're looking at what he's saying, testosterone and some of these different antidepressants, there's so many. Prestique is one of the newer ones, and they're just kind of modified versions of the old ones, which I've learned that from him. And you want to get an expert, guys, a medical expert, that not a PhD, that's a psychologist, that's cognitive behavioral therapy. In my opinion, and the psychiatry guys, again, I'm here to tell it, I'm kind of rough and tumble now because I've just been doing it so long, and I work with long days, guys. I get burned out. So I'm just tired of it. So the medical management in the psychiatry world, and Jason, I'm sure you're going to agree with this, is kind of annoying that the MD guys are aggravated because they've lost a lot of money and they don't have any power anymore. So they want to make money. They don't take insurance. And they just do, they can give the medicines, you see. Now, some of them are great. They're going to do a history. They're going to understand on the physical, right? That's internal medicine, right? They do the history. They really understand it, and they know how to use those drugs. I'm telling you, they know how to fingerprint those drugs. Now, with guys like this, he spends real time, and he does cognitive behavioral therapy on top of the medical management. That's the holy grail. I'm telling you right now, 2 + 2 is 5. Because and it's not done. The psychiatric guys, except for LA, right? In Los Angeles, the famous psych guy. Look, they're basically giving pills, but they're not really giving it properly. And again, not the top in the world where it's $500 or $1,500 an hour. That's better be a good guy. For real people to understand the medicines and the cognitive behavioral. And then on top of testosterone and what you have, and then your ABCDs. All right, let's keep going, Jason. I know we're getting pushed because we got a lot of questions. Go ahead. This is for Whitway.
QEEG. Geez, can they
Help you diagnose plan for anxiety. Oh wow.
I'm sorry, I'm not familiar. Let me look what that acronym means. I'm sorry. Give me 1 second to
That's right.
see what that means, because I might not be thinking it's the same thing that this person is. Let me see here. QEEG. Go.
And there's so much technology now, but we
Brain. Okay. Oh, okay. So quantitative electroencephalography, brainwave function, comparing digital EEG. Okay. What is my position on those? Well, I can't say that that's really a taught standard. I don't remember any of that in residency at all. However, if you're looking at it as an alternative to an EEG, if it's more in-depth data, okay, that's fine. What I would tell you along with an EEG, it's not a standardized test by itself. Can they help either diagnose or plan treatment for anxiety or depression? And is there any tie-in with testosterone level? So is there a tie-in for anxiety, depression, and testosterone? Yes, there's an inverse relationship, meaning your testosterone is lower, you will have higher incidence of depression, you will have higher incidence of anxiety. No doubt about it. That's a truism across the board from what I've seen. There may be many people with depression and anxiety who have, quote, in range testosterone or acceptable testosterone, or they're not having symptoms aside from anxiety and depression that are consistent with, say, hypogonadism. However, I have yet to see somebody in my clinical practice, and again, I've been studying androgens and anabolics and the health effects for going on 3 decades now. I have yet to see a single person with that who did not have concomitant anxiety and depression to some level, meaning it's naturally occurring. So do I think that QEEGs can diagnose that? Absolutely not. No. I will not look at a brain image and diagnose somebody with depression or anxiety. Absolutely not. What I will use to do that is I will use what's called the diagnostic clinical interview. Now, are there questionnaires? Sure. Are there some that are very in-depth? Yes. Are there some that are common, like, PHQ-9? It's 9 questions, hey, how you doing? Are you mad? Are you depressed? Have you thought about harming yourself? And that's wonderful in the primary care setting. In my setting, there's a litany of them, whether you're doing academic study, whether you're doing, more in-depth diagnostic clinical interview, there's Hamilton, there's Beck, there's all these scales, right? There's, Montgomery if you're doing an academic setting. But realistically, what's important is the clinical diagnostic interview. Do we have the Diagnostic Statistical Manual 5TR, revised version of the 5th version of the DSM to guide us on basic minimal diagnostic criteria? Yes. But for me, what I look at in terms of anxiety and depression is, how does it impact function? How does it impact the person? Because there's a line of what pathophysiology is to where it's diagnostically appropriate versus what's the actual clinical impact? Where does the rubber meet the road? And for me, for depression, anhedonia, and evolution. Do you enjoy the things that you do, and can you even get out of your own damn way to get there? If you can't do those 2 things, those are big impactors for me. Or if you have so much anxiety that it's negatively impacting you socially, it's negatively impacting your work life, it's negatively impacting your family life, you can't even make a decision on what to eat for dinner because you're so upset, right? And anxiety covers a lot of different so-called disorders, but if you take somebody with, say, obsessive compulsive disorder, I'll pick on that, right? Because that's in the common vernacular a little bit. I'm OCD. If you really knew what OCD was, you'd never say that, because those people are truly suffering. It's a functional disability. But if you take some of the traits, right? If you take just a little bit of the information, like, do you not leave something dirty? Does it have to be clean? Does it have to be organized? You take somebody like that and you put them in charge of a car detailing business. Now that's a superpower, and they're making millions, right? Because they have an incredibly high standard and they won't leave it until it's done. Now you take that same person and they can't get out of the house until they touch the stove 4 times to make sure it's off, touch the doorknob 10 times, rearrange the drinkware to an exact series of 3 for 3 series of 3, and oh, this one's off. I got to start my ritual all over again. Now they're 2 hours late to work. They've done that a few times in a quarter. Now they're getting suspended. They're getting fired. They can't pay their rent. That's pathology. Now, do I think I can just look at some brainwaves or something and say that? No,
you know what's
because
amazing?
The pattern might be the same.
Here's
I
guys.
don't know.
Right. So I don't even know what this, Q, I work from the chin down. But look, if you work from the chin down and we could look at inside the coronary artery, it's the coronary artery, as important as it is, it's not an emotional thing. Okay. Blood pressure. My ABCDs are completely non-human. They're just metrics. And that's why they're so easy. Now you go, how can you now? Can you look at a PET scan or an MRI, and this is where it's scary. Can you look at a pattern? Not to mention with AI and machine learning, that hey, it looks like you're headed toward depression. This is where it's scary, guys. That's why we got to be careful, because when you look at gene analysis, this is where it's scary. Doc, do you recommend the gene analysis? Well, do you want to know that you have genes? You have genes for Parkinson's disease or Huntington's. Check out what that is, or ALS. And then, holy shit. And then, but they're not on the on position right now. Mm-hmm. So you're waiting. Oh my God, honey, today's my day. I had a little misstep. I was walking a little. Don't do it. ABCDs. We're not ready yet. That's my opinion. Yeah. And I want to see someone argue me. Are those genes going to turn on? And why would you want to know? He's asking questions with a clinical diagnostic question. How do you feel? If you feel great or you don't feel great, he's here. That's how can you look in the brain? That's neurology, and that's going to be motor neuron, MS and Parkinson's. All right, next question. Next question, Mark, put it up again. Hey guys,
the amount of testosterone. Okay. In regards to physically in regard to organ demand. Okay, so, Mr. Young, let me answer your question bluntly. I appreciate your candor, so I'll share some of mine. Depends on the individual. Is it a gram? Is it a gram in 2 milligrams? Is it 800 milligrams? I have no idea. How about we look at this another way? What's the least effective dose that I need in order to get a desired result, which is feel better, have recovery, have an increase to normalize for the person libido, for the person to be able to sleep, function, have a return of mental acuity. If I can do that with 100, why do you want me to put you at a gram so you can spend 10 times the amount on product and do 10 times the potential organ damage? We're not looking at the quick hit here. We're looking at time under tension when it comes to muscular hypertrophy, right? We can all agree with that, whether it's high intensity or if it's volume, right? Because, there's some debate there. But realistically, it's time under tension, right? and quality of effort, right? Organ damage works the same damn way. Think of the kidneys like a fine mesh. And you want a nice trickling garden hose, peacefully and passively running through it, so it collects all of that waste and it gets rid of it. Blast that thing with a fire hose. It doesn't matter how strong your mesh is. It might be a little stronger than the next guy's, but eventually it's going to tear and do that. Congratulations. You're on renal roundup, going to dialysis 3 times a week and hoping to not die. And don't drink any Coca-Cola because you're going to scratch the hell out of yourself because your phosphorus is going to go through the roof. Same principle. If you induce cardiomyopathy, you're going to be someone who has diminished capacity to walk up the stairs, to have sex with your partner, to have normal brain functioning, to be able to walk. Why would you possibly look at it like, what's the most I can do? Reverse it and say, what's the least I can do, and then get a desired effect.
Right, and then let's go to this. Was that the question? Was that?
Yeah, that was this question. Yeah,
that was it. Was like, what's the? Okay, I mean, it's great questions, and it's kind of rudimentary. Kind of rudimentary, but it's like, let's go back in the day, and we won't say Schwarzenegger again, because I really can't. This guy is just, he should, before he checks out, he should try to do something about harm reduction for all the stuff that he and all the guys back there really created with all the money, but it is what it is. So, back in the day, guys took Sustanon 250, they took 1 cc, and even that was like, they benched 500. I mean, guys, I am not kidding, because they put the work in. They waited to start steroids until they're 23, 20. It is true. It is true.
Mhm.
Not many guys back in the day, I'm talking 70s and 80s, 90s, things started to change. That were doing, not many guys did steroids at 19. Now we have you guys at 16 or 15. And I know it's
Oh, yeah.
peptide. I know it's peptides. And I know and I know we're doing research on it. But so I want you guys to really understand that, like, you want to do the little bit. Again, we're prima donnas because we've been there for years and years, but we're not coaches or gurus. We're board certified healthcare practitioners. He's a psychiatric guy. I'm an internal medicine. So we're really trying to give this good information. So everyone's jumping on everything. If you feel good and your testosterone levels are normal, which could be even like 300, because what's your free? And if it's normal, you take the number, you put it to the side. Don't treat numbers. Okay, treat the patient. Sir, how do you feel, brother? How are you feeling? Don't do it. And but you want to join the club, join it. What's more important, total or bioavailable? Jason, go ahead. That's your question.
So, let's look at that with complete information, right? So let's take a look at the sex hormone binding globule to see how much is bound up. So I'll give you an example of a real world patient. We'll call him, Bob Smith Jones, whatever the hell his name is, right? For HIPAA. So real world case, total testosterone comes back at 600. SHGB, and I repeated it, and it went from 72 to 68, so it was astronomically high. And free testosterone is down in the low 20s, and then came back again at 18. So I said, okay, we have a problem here, Houston, right? Because if I just ran the total, hey, you're fine. The guy can't sleep. He's having some erectile dysfunction. He's scatterbrained everywhere, and he's like, I was the most organized guy ever, all through, primary and secondary school. The guy's got multiple degrees, and has a very high demanding job, and he's like, I can't function. And he goes, I feel like a cat on a couch. And I rule out everything else. Like, okay, what else are you taking? Do you have alcohol? What are the medicines are you taking? And so I loaded the dose of the blood pressure medicine he was on, because he didn't need to be on that high of a dose, because he was on a diuretic, and he was on a beta blocker at a higher dose. So I just lowered the beta blocker. That helped a little bit, but he's like, comes back 2 months later, he's like, I still don't feel good. We repeat the numbers, and I'm like, okay, yeah, well, look, your available testosterone is low. Your sex hormone binding globule is grabbing the majority of your testosterone and hanging it, so it's not being deployed to be used. So with the complete information of all three of those numbers, I guess I would say it depends on the guy. I get, maybe it's free. I don't know, but sometimes that's not all the way the answer either.
Let me pick up here. This is obviously, you're a brilliant guy and you're experienced. You're a testosteronologist, but let me also, because I've been studying this for so many years. So here's what it is, sir. Really. So the total testosterone. If you think of testosterone, it's oily, right? Think of it oily, right? So if you inject testosterone, it's all oil-based esters. And that was from the 1930s. They discovered it. And then into the 40s, 50s, and 60s, they really processed all these different steroids and played around with them with the functional groups. And we have orals and injectables. And so if you look, and then you look at the human body, think about this. The human body, this is spiritualism right here, guys. So we all come from the ocean. No one's going to, I don't care what religion you are. I don't care if you believe in God or not. We come from the ocean, right? Because we have salt water, right? Nurse, 0.9% normal saline. Let's go. Give 700, give a bolus. So you don't give water. Our veins are we're not circulating water. We're circulating salt water. From osmolality is different than the ocean, depending on what ocean you go to, but it's similar. Isn't that crazy? What maintains it? Well, your heart pumps it, and your kidneys maintain that osmolality with the sodium and the electrolytes and the freak it. That's religion right there. Now, that's salt water. Do you know that oil and water don't mix? Here's how I explain it. Oil and water doesn't mix. You're a Goomba. You're going to make some spaghetti tonight. You're going to put the big water. You're going to put a little olive oil in. It doesn't mix. It goes into separated area, the water and the oil on top. So everyone knows oil and water doesn't mix, right? Because of the hydrocarbons with the aqueous. So how does your body, so your testicles make testosterone. Forget the adrenal stuff. Your testosterone, 99% of a man's testosterone, again, is 99 point, is your testicular testosterone. It's oil. It's not oily like cypionate or enanthate, but it is fat. It's in cortisol, right? So how does your body distribute oil in water? It uses binding globulins, like he just talked about, sexually binding globulin and albumin. So when you look at now when you inject testosterone, that has to be picked up by the albumin, the sexually globulin, right? It's only about 60% sexually binding globulin. The other percent is made up mainly of albumin and other sundry globins, all from the liver. They hold it and they circulate it in your body. Now, when you look at testosterone total and free, the standard in the assays with the liquid, the chromatography that we have, the mass spectroscopy, the labs, total is what's measured on the carrying globulins. If you have more, like he's talking about, you're going to see a distortion in that. Now, if you have more, that will have more binding globulin will hold on to testosterone. It's transporting it in the circulatory system. It doesn't leave the circulatory system. Well, when you're transporting testosterone from your testicles or from the injection site, and you're bringing it all the way around your body, and they're like little cabs, right? The cab stops in the brain, and then the testosterone molecule has to go out of the circulatory system and go through that brain barrier, phospholipid bilayer, and make its target to hit the nucleus, right? The androgen receptor. Come on. I don't care if it's a muscle or if it's, so when you do that, that's free testosterone. You see, so when you have a disparity in that, it's because of the testosterone sexually binding globulins, and it's quantitative and it's also qualitative. Some of them are very strong. That's what he's saying. So the real answer is the standard of care. You kind of have to look at both sexually binding globulin, understand this is why testosteronology is here. And then in the end, it's the free testosterone, but you have to understand the metric of the free. Is it, have you checked it? Is this guy natty? Is this guy on SERMs, selective estrogen receptor? Is he on testosterone? Is it peak? Is it, again, it's the endocrinology guys I have a lot of respect for diabetes. They don't know this. This is a full day job. And then some of them do, good for them. It's a full day job. You can't know it all. But this is how you diagnose and you manage when you look at the total in the free. It's embarrassing when healthcare providers just look at that total. That's a strict embarrassment. And all the bro science guys, that's why they have no respect for doctors, some of them, because my doctor checked his testosterone, it's 700. And then Jason goes, oh, I checked his testosterone. Yeah, it totals 700, but his free is low. It says low because his sex hormone binding globulin, because the quantitative and the qualitative aspects, which are a whole nother animal. Why do you have high? Obesity, thyroid, depressions, drugs. This is our day job, okay? And you have to understand that to make a diagnosis. And then not to mention, there's implications on that when you start managing and injecting. And how about oral steroids? How they lower that. Other drugs, alcohol, drugs, all these steroids and all these peptides, they have effects on sexually binding globulin. So therefore, they're going to have downstream effects on how you read those labs. Again, that's why it's testosteronology. Great question. Let's go to the next one, Mark. Tell us a little about. All right.
Well, let's see here.
I know that.
Low dose Paxil for hot flashes caused by unbalanced hormones. Well, I can tell you this. In my practice, I refuse to prescribe Paxil. I will not prescribe that drug. I think it is one of the worst ones, period. That being said, I know that there are providers that will say, I've saved people's lives with Paxil. It's wonderful. Good for you. Paxil is one of the hardest drugs to come off of. So here's my thing, right? This is, I didn't learn an algorithm. I don't care about them. I can teach a primate how to do an algorithm because I'll color code it, right? And that's not to shit on Dr. Osler. You're the brilliant guy. But, that's not how we should learn things. Neuroendocrinely, neurochemically, what does it do? So how does it affect the brain? And then how does it travel through the SIP system and then the renal system to ultimately get rid of this, right? Because that's the total effect of the drug. So paroxetine, Paxil, it's one of the hardest drugs to come off of. So in terms of treating a hot flash, well, why are you having a hot flash? Why are you having it to begin with? Are you menopausal? Are you premenopausal? Why don't we run some actual labs? Why don't we see where your progesterone is? Why don't we see where your estradiol is? Why don't we see where your prolactin is? Why don't we, make an actual diagnosis? And that's not to pick on the writer. No, this is a very good question. I'm glad you asked it. But in my opinion, I think Paxil ought to be thrown in the dung heap of medications. I think it's terrible because I've seen people suffer for years to come off of it, and it's very difficult to balance that with another medication to cross taper, because people have horrible untoward side effects as you do it. The GI effects from the serotonin reuptake are multiplied while you try to do a cross taper with it. Then you're having to use maybe, potentially more of a dopaminergic drug like a neuroleptic to take somebody off of it. I think paroxetine is a horrible drug.
What's an alternative?
An alternative in that same class, escitalopram, Lexapro is a good one. Even lower dose sertraline. I know I pick on sertraline quite a bit, but I have patients in my practice who they do fantastic, men and women, both on sertraline. And I check their testosterone and their estradiol levels, and they're not affected by it. They're doing awesome. So I'm also a big fan of, if it ain't broke, let's not tinker with it until we do.
What dose? What's the dose?
73 RS Camaro, right? Constantly tinkering with the carburetor on that thing to get it to go faster, right? And some days, it'd work out great. Other times it'd be like, wow, I ran it a little too rich. Same thing with psychotropic drugs. If they're working, leave them be. But, if something isn't going to have a good downstream effect potentially, don't start it. That's why we stopped giving TCAs or tricyclic antidepressants. It wasn't because they didn't work. It's because we came out with drugs that were safer in terms of total side effect potential. That's why we stopped using those. So that's my view on paroxetine. I'm very biased against it because I've seen.
It's interesting. It's just so cool, guys. What about Wellbutrin to help with drive?
Add focus. Oh, good Lord, yes. So let me qualify that with, in my experience clinically, because I specialize in addiction medicine, I will only use Wellbutrin or bupropion as a generic. As a standalone medication, I will only use the XL, meaning the 24-hour acting, because short-acting Wellbutrin, you can run into having to take it multiple times a day. So you make somebody take something multiple times a day, you have adherence issues where people forget. Or God forbid they double up because they forgot they take the morning one, right? Or, the XL is enteric coated. It's only meant to be broken down in the stomach. So you can't have it take too quick a clinical effect if somebody holds it in their mouth a little too long. And then I was like, wow, I just got whacked with like 4 cups of coffee from this Wellbutrin, because it has that kind of effect.
Wow.
I do treat, ADHD. I am not an ADHD specialist. I don't claim to be, but I stayed at a Holiday Inn last night, let's say, right? So I know how to treat it with or without a stimulant, right? Because we love stimulants in the US. And stimulants have their place. They're fantastic medications when used appropriately. I use off-label Wellbutrin to treat ADHD.
Wow.
I use Wellbutrin, to help folks with, some craving, and also some antidepressant use. It's a good all-around drug. Mm-hmm. That being said, there are some folks who do not do well with Wellbutrin. It's really fingerprint medicine. And it's based on the art of prescribing, which we had talked earlier about genetic testing. Here's why genetic testing will never replace the clinical interview and the clinician, because I can limit it to a top 3. But I got to base it off of what you've done before. I want to know what didn't work and why and what happened, because then I know what to stay away from. That's a reasonable facsimile thereof how it hits the SIP system in the liver, for how you're going to break it down, or other drugs you're on. So I don't practice on an island. To me, the primary care provider, they're the quarterback. I'm the specialist, right? I'm the expert specialist consultant. I'm the third and long guy. So the quarterback calls the plays, meaning we're on this for blood pressure. I want to use this for psychiatry. There's a direct counterindication for these two drugs. They don't play well together. The primary makes that call. I don't, because I'll find something else. We can get a different play. But if your blood pressure's stable and I start messing with that with a psychotropic, how's that total health? You know what I mean? So the same thing with the Wellbutrin. It's wonderful for concentration. The only potential with Wellbutrin that I've seen clinically is it can cause some transient sleep disturbance. Every once in maybe, 1,000 people, let's say, it could cause a little bit of sexual dysfunction if it's too high of a dose. But that's very rare, very, very rare. And, for some people, it can induce hypertension. Anything that messes with noradrenaline, potential for hypertension. But some SSRIs can cause cardiac disturbance too. Like if you go higher than 20 milligrams of escitalopram or Lexapro. Being a prudent provider, you will obtain a cardiogram ahead of time because you want to get a baseline. Or if somebody has an advanced cardiovascular history before you start a Wellbutrin, you'll get a baseline EKG, or maybe might even send them for an echo depending on what age they're on. Because I've got patients in their 70s I put on Wellbutrin. I also make sure that I have a consult usually with the primary to say, okay, what do you think? Can you send me some of their cardio, info? And if need be, we'll get a cardiologist involved. But that's rare.
Okay, excellent. Any other questions, Mark? We got any there? Let's see. Any tips to help tolerance to stimulating effects of things like that?
Caffeine and TRT over the years, when tolerance to caffeine has dropped, I get panic attack symptoms in TRT injectable. Oh, hey, great question. Boy, am I glad you asked this one. So I am a big proponent of caffeine, right? Caffeine's fantastic, right? Until it's not. And where that level is, I have no earthly idea. That is up to the individual. Every year, I kid you not, every year, and I've been in medicine in one form or another since 1997. Every year, somebody comes out with a study that says coffee's terrible for you because of caffeine. The same year, if not halfway through the next year, someone else will come out with a rebuttal study to say, bullshit, coffee's good for you. And so is caffeine, right? So if you're having panic attacks from caffeine, give the caffeine a break. Also, take a look at the timing of your caffeine. So one of the big things with caffeine is time of administration. So when you wake up in the morning, one of the things, it's a very complex series of on switches that need to have you wake up, starting with the hypothalamus to turn up the body temperature, right? Caffeine directly blunts adenosine triphosphate, or ATP. So let's think back to science class to what ATP does. That's the drive, makes the cells move, makes us move, right? That's the ultimate power factory in the cell, ATP, right? In the mitochondria. Not to get too technical here, but caffeine directly blocks that. If you block the burning off of adenosine triphosphate, that's why you get an afternoon crash. That's why you need more caffeine. The longer you can delay that caffeine intake, the better. Now, some people that might be 5 minutes. Other people, the ideals in the academic studies are 2 hours. I don't tell my patients that because I live in the real world. It's like, hey, let's shoot for 20 minutes, half hour. If you can do an hour, fantastic, right? But if you're having negative cognitive effects, negative health effects from caffeine, then switch to half calf. You have to have your cup of coffee in the morning, right? Okay, go ahead. You're drinking soda in the morning? Well, I'm sorry, you're just wrong. Stop drinking soda in the morning. That shit'll kill you. If you're having energy drinks, try to get one where you can pronounce the majority of the ingredients, please. Because we all have them, right? And they're not terrible unless you're really super sensitive to it, or you just can't pronounce the ingredients, right? If your grandmother doesn't recognize what the name is, you shouldn't eat it. Same thing with some of the drinks, right? So, in terms of, I'm sorry, Mark, put the question up one more time. There was a second part to the question. I get panic TRT injectable. Okay, so TRT injectable, how many times a week are you injecting? I'm willing to bet dollars to dimes this person is injecting once per week. So my suggestion would be to spread that out to multiple times per week. If you're doing an intramuscular injection, I would say let's maybe think about switching to sub-Q, and let's have things build up a little bit more gradually, because I'm guessing the rebound increase in the estradiol is either inadequate or it's just too much. We need to find a little bit of a better balance. So I think in the short term, simple, maybe we need to lower the dose, maybe, right? Or we need to spread out the frequency, or maybe both, or maybe we try a different ester. I don't know. I don't know what this person's taking for their TRT. Are they on a pellet? I'm not a big fan of pellets, but some people love them. They're big in South America, from what I hear. They're big in the Southwest United States, from what I hear too. But I'm not a fan of them. You can't adjust the doses, so that I guess I'd like a little more info on that to really answer the TRT one. Used to be able to tolerate any stimulant caffeine dose. Now my body started having issues with them getting out of a cup of coffee anymore. Okay, so stop having coffee. I know that sounds like a simplistic answer, but look, here's the thing: if you switch to a green tea or an antioxidant tea, you're going to still get a lot of the same benefits of the GI movement, which is a lot of what coffee will do. That's why a lot of folks like to have it first thing in the morning, right? There's a great Black Rifle coffee company with somebody running right to the bathroom if they have a sip of the thing, right? And it's like, yeah, that's why I drink this every day, right? So that's what I would highly suggest. That there's also there's a mushroom based one. People really like that. It gives them a lot of the same antioxidant. It has neurotropic factors in it as well. Maybe if you're hypersensitive to caffeine, maybe something like potentially an ashwagandha might be a little bit better. I don't know. And again, this is not medical advice. I'm a nurse practitioner. I'm not your nurse practitioner. This is theoretical. So maybe theoretically consider some of those switches.
Let me say this. The injection anxiety, right? So that's kind of my world too, completely. So guys, here's the thing. So I think he's right. If we're just gambling here, we don't know, right? And when you're on the health portal, you ask questions, we're going to give you answers. Me, Jason, right? And then we have at the top, I really call it the chosen ones, right? There's 26 on our directory. We have 60 under training, and it's been a lot, right? Jason comes to all the meetings, and I've learned from him. He learns from me. So go to the health portal. If you have questions, guys, join up and then understand everything so we can really take care of you appropriately. Now, the question, so many guys get anxiety from testosterone injections or any injections. So there's needle phobia, but beyond that, I think he's right. So you're injecting this injection that's intermuscular injection, right? Either in your deltoid, right, or the glute, the ventral glute, and the leg, right? Or I don't want to hear like the bodybuilders are injecting in their lats and all that. That's just on the traps. That's crazy. Okay, so these are regular people here. So small doses. Another thing is this. Let me give you a little secret. My wife is my nurse practitioner, my nurse, and she's working with us. Nurse Wendy, shout out. She's so good because she takes care of all these with me questions that are so logistical but so important. So she'll offer different. Hey, let's do a Zoom. Maybe I can really work on your technique because it's painful. You're injecting in this part of the quad. Try this or try. Wow, Nurse Wendy. Or in the end, for the last year or two, we have something called Zyosted, and I'm not your doctor, right? And he's not your nurse practitioner. This is not medical advice. This is strictly information and education. Now, Zyosted is and I'm not selling for Zyosted. Zyosted is testosterone enanthate in a pre-filled auto injector syringe. They have a patent on the syringe on the auto injector, not enanthate. But let me tell you something. So many patients, and you can inject it intermuscularly in your leg or subcutaneously in the belly, like a growth hormone shot or something like a standard insulin. And so many men love that because you just pop it in and it auto injects, and it's not completely painless, but it's a pinch. So a lot of people like that. But you know what the downside of that is? It's expensive, and insurance companies, they're denying medical care for women for people that are dying with cardiac disease. So they're not going to pay for this stuff. They deny everything. So Zyosted, and he's right. Small injections, learn how to work around it. What else, Mark? What else we got? Does tafalafil lower? No. Tadalafil. I think he means tadalafil. Yeah. No, absolutely not. No way. That's a good question. So the best This is like a Dr. Michael Scally. Check out who that guy is. That's the old school guy, right? He lost
Oh,
his
yeah.
license. He lost his license about 20 years
Oh,
ago.
no.
Yeah,
Oh, it's
well,
terrible.
no, it's old school, and he's a good
Yeah.
doctor. He's a
Oh,
good.
yeah.
He was like the first anabolic doc. I don't know, but I got the name. I bought it for $9. Maybe a couple years later in 2007 or something. Okay, so Michael Scally lost his license. Okay, in Texas, and it's just sad for him because he was kind of doing what I do now, harm reduction. He wasn't giving freaking steroids to people, but might have been going over the edge a little bit, and it was bad timing, and they pulled his license. You could fact check that. Doesn't mean he's a bad doctor. I think he's a great doctor, but he was in the wrong time at the wrong place. So, but he has brought up that you want to lower your sexual binding globulin, guys, and he's not advocating for it. Oral steroids and DHT-derived steroids, most of them. We're not going to go into a rabbit hole, but then in the end, we always say, and he agrees with this, that you lower your sexual binding globulin, you liberate your free testosterone. Yay! What are you living on freaking Anavar and Winstrol, oral Winstrol forever? It's not sustainable. Next question. Let's go. Would love to be able to talk
Methadone and opiate recovery.
Oh boy.
Okay. Oh, great question. All right, so let's see here. While using anabolics, so we finally have data through SAMHSA. Just kind of the be all end all in terms of data collection for addiction. Certainly in the United States anyway. With respect to mu receptor antagonists, which is all opioids, right? So all opioids lower. Same thing with alcohol. Alcohol and opiates lower testosterone. So we're now with SAMHSA, substance abuse, mental health is kind of their big umbrella thing, the big federal agency. Right? A lot of funding comes out of that. They've come out with a positional statement saying if you're on long-term opiates, it is judiciously prudent for your provider to be pulling your testosterone levels because we have proven, with many, large cohorts, thousands of people who have had, lowered testosterone, maybe not to the point of it inducing, classic hypogonadism by, American Endocrine Society standard, but certainly to where it's negatively impacted quality of life. Because, chronic long-term opiates or chronic long-term benzodiazepine, chronic long-term alcohol abuse will lower testosterone.
It absolutely does.
Will.
It absolutely does. And up until recently, that was just in my book, that was just such a cringy miss by so many healthcare providers. Do a health history.
Oh yeah.
And part of the psychosocial history. Please, brother, you're here. It's confidential. Tell me about alcohol and drug talk. I'm okay now, but I'm on Suboxone, doctor. And, I'm with the grace of God, I'm okay now. And then that's why I have low testosterone, doctor.
Yep.
So Jason is being very nice. And I can tell you the data is alarming data on opioid. And I want you guys to fact check it. But it's just like, how many guys in the bodybuilding world, and what's that guy, Doug Froshi? Remember Doug Froshi? Doug Froshi, super famous bodybuilder, died about a year or two ago, either committed suicide he was in the world of real heroin addiction. Yeah, he was an IV drug. Yeah. He was an IV drug user. Yeah. And then he came out and this is the sublimation. This is the sublimation of someone that comes away from the drugs and alcohol, puts all that beautiful energy into, again, bodybuilding and clean and sober. Of course, but he was just such a sweet guy. I met him at some of the conventions and stuff. You could just see the soul and the energy and this want to help everyone talk. Just a sweet little baby guy, but a monster. He relapsed. I've seen other guys that have this paradox where they clean themselves and they transfer, to transpire, to transcend, to getting off drugs and alcohol and depression. This is why we're here. And they find training and exercise, and that's fun. And then they get into maybe a little bit of the steroids, and then they're subliming, right? They're transferring this energy, which could be positive, but then that if you don't treat, this is what they've told me, if you don't identify the underlying pathology that we all have from a psychiatric. It's that lump in the rug. It's just there. It's the elephant in the room, and it will it's gonna pop its head out. And you see that in the bodybuilding world, where there's so many people that are finding this beauty and this incredible energy of again, clean and sober and training and positive and turning your life. And then again, I'm just saying, you get on some testosterone, and if you can keep it to that, if that's what works for you, but it's a lot of times it's a slippery slope. And and again, this is our life. And again, I want you to be understanding that, and to understand the effects on this, on the cognitive and the depression. This is why, Jason, I knew this was going to be such a big night.
No. So methadone, it's not as common as it used to be, in terms of addiction medicine. What we're finding now a lot is that it's used in pain management in lieu of oxys or the like, right? Which has its place, sure. Personally, I'd rather use Suboxone, or I'd rather use just straight buprenorphine patch, or then again, this would be off-label. And to be clear, guys, off-label means that we're taking liberty as a provider to understand the mechanism of how a medicine works and use it for a non-FDA approved indication. Doesn't mean we're doing something that's not safe. It doesn't mean we're not doing something that's clinically prudent. It just means it's off-label. It wasn't studied for this specific purpose yet. You can use Sublocade. Now, if you're using long-term, addiction management, in my opinion, if you could do, Suboxone or buprenorphine tabs or pills, think about doing the injectable. Think about doing 1 shot per month, and you're covered. And that's going to stay residually in your system. What we're finding through people telling us when they tried to come off of it, they didn't have cravings for up to 6 months. It has such a long half-life. Where if the pills, you forget about it a little bit, or, you're a little tempted and, all right, shit, I just won't take my Suboxone for a couple of weeks and I'll be fine. And then I can go use, with all the fentanyl that's out there, it's a big gamble, right? And, you also have tolerance going down, from where you used to be able to have a certain amount. Now it's going to be much less, but it's magnified by the fact that there's either fentanyl or, God forbid, carfentanil in it. Using like a Sublocade with the provider that understands that this is going to potentially lower your testosterone, you could treat the testosterone and addiction. They are not mutually exclusive.
I do it all the time. I've done it for years with experts like you, with guys like you. It's a great synergy to especially for the sexual side. Put a little testosterone in there and get the guy, and then it's a perfect. And the patient's just so. What do we got?
And another Testo and I were actually just talking last night about how many people do you know in the bodybuilding community, in the gym community, that quite literally going to the gym and dumping the emotional pain for some physical pain through hard, vigorous exercise has literally saved their damn life.
Absolutely.
And I'm like, yeah, I know one.
Right.
We just don't want, without a doubt.
We just don't want the steroids.
Without it.
We just don't want the steroids to get out of hand, and just keep it on testosterone. Let's bring back the old school. Mark, any other questions? Here we go.
Hit workout above average. You did 3 cycles within 10 years. Last one 7 years ago. 300 DECA, 400 tests. 6 weeks ago for 2 weeks because my blood pressure went up and got tachycardia. Okay, so 300 of DECA. I'm assuming you're talking about decaduroblin or nandrolone decanoate. 400 of testosterone. I'm assuming that you're speaking about either cypionate or enanthate, because not too many people are doing 400 of test prop in a week. That's a lot of injections. And 6 weeks ago, blood pressure went up. Yeah, you're boosting your DHT, which some people are very sensitive to DHT. You're probably boosting some aromatization as well. So yeah, your blood pressure went up. Okay, so theoretically, you're a 50-year-old guy. If you're in my practice, I'm going to take a look at one, where the hell are you getting it? Because are you getting real gear? Number one, right? That's the big concern. Is it actually dosed at that? Meaning, did a very excited chemist, as opposed to 300 milligram, or 200 milligram per cc, it's 250 or it's 400 per cc. I don't know. No idea. I don't know if you get your stuff third party tested. I don't know if you know the chemist. I don't know if it's someone making it in a lab, or I don't know if it's some Rudy Poo making it in his bathroom, with sawdust off the floor and cat litter. I got no idea. Hopefully it's not that. Hopefully your gear is clean, and then there's just the risk of heavy metal contaminants. So there's a lot to think about, right? So is it raising your blood pressure? Is having the potential, depending on your familial history, of having a heart attack or a stroke worth whatever size you're gaining from that amount of gear? Now, you could be the biggest guy. You can be awesome. You can put on 30 pounds. That's cool. Go ahead and have a stroke, and you're going to be sitting in a wheelchair with somebody wiping your ass for you for the rest of your life. Was it worth it? I don't know, man. You start getting too hypertensive, it's bad news. Please go see a provider, get your blood pressure measured. Would I still work with somebody theoretically like this who said, I'm just going to stay on this, just manage my blood pressure? Yeah, I'll do harm reduction. I won't endorse what you're doing because I don't know where the hell you got it from, and I don't know why you're doing that amount, but I'll have a conversation with you, and I'll certainly treat your blood pressure. Absolutely. You do not want to have unmitigated hypertension. The downstream effects of that are horrible. Worst case scenario, you're going to have to hire some pretty strong pallbearers because your ass is going in the grave.
But let's go into it. I just love to hear you talk from another perspective, right? So, all right, guys. So I'm the harm reduction guy in the world, and I do the research, right? So I've been doing it for a long time. Sir, you're doing 700 milligrams a week of gear, old school test and DECA. It is what it is. You did some cycles way back when, instead of just hopping on the gear, you're 53, dude. I mean, you ain't no spring chicken, sir. Okay. You ain't no spring chicken. So have you, and it's so many guys. I'm in South Florida. We go out, my wife and I go out and a couple of times a week sometimes. And my wife just goes, man, look at that guy over there. He's your age or older, and he's just yoked. I mean, so everyone's on everything, but it's like at that age, not to mention, even if you're 20, 23, okay, let's take the young guys out of it. They just don't see mortality. They're warriors, and that's just built into our genes. And then you put it on testosterone, that's a whole other animal. But let's say you're 40 something, right? You're getting older and you're on some testosterone, running some stuff, I hope not trend. And I don't know who trends for. I just don't. If I want to legalize steroids, which one day I'm going to be working on for harm reduction standards. First of all, we already have testosterone here. We have Anavar here, right? And we have nandrolone decanoate, right? I mean, so we got 3 other countries just drool at us because they're like, you guys really have it. It's all you really need. I mean, right? So, but when you look at this guy, sir, why don't you just go on testosterone, say 200 a week, and then check your heart with a CT scan with a calcium score, or if you got a couple of bucks, do the CT angio with the annotated plaque analysis. I mean, this is where the big money. This is where the Silicon Valley guys. I got a few of these. I got a bunch of these guys. Again, they want to make money. They want to have great erections, and they want to go to board games and board meetings, and they have little baby muscles. And because they're smart guys. They're just money guys. They're power guys. Okay, they don't want to have a heart attack and a stroke, and they don't want to lose their brain, like he talked about. This is called vascular dementia. Go to Google. How much of dementia is vascular? Up to 50%. Holy shit. What causes vascular dementia? ABC, A1C, blood pressure, and cholesterol. Forget your gurus. That's the God's honest truth. Now, blood pressure. Sir, you had palpitations, I think, or you had some tachycardia. I think he said tachycardia.
Yeah, he did. Yeah, he said tachycardia. Yeah.
Sir, you got to be careful, bro. Go to this guy. Go to one of my healthcare providers. Slide into home base. It's all confidential. We've done this. We're allowed to do this. This is the top of the top. This is not anti-aging or wellness. This is real testosteronology. You're on steroids. You're on testosterone. We want to protect you. You're not a baby. You're not a kid. Okay? You're a man. You probably have, if I'm gambling in Vegas, you have a family, you have children, and you don't want to have disability. You want to live a long life. This is great, sir. I know it's great. But you can do your ABCDs. He could help you do it. He could do it. My providers can help you. The app you can get on Testosteronologist. It's not an app anymore. I couldn't stand on being on iOS and Android. This is a waste of money and time. Let's get off that. We have a great developer. We're on testosteronology.com. Okay, guys. So sir, it's just like, you don't need all that, dude. You don't need all that. This is 100 milligrams every 5 days. I'm not lying. And maybe some baby doses of nandrolone, because I do like it for the musculoskeletal, and I like the effect of the cognitive. We're not going to get into the sex stuff. I don't want to be creepy and weird. I don't want to be a creepy weird guy. But it's just like, it's true. And Decadick, like, you take all that, sir. Google Decadick. Okay, this is old school stuff.
Too much DHT. Yep.
But you're not going to go down the rabbit hole. I'm going to take cable. Again, bro science guys are incredible guys. These are bright guys that are experimental guys. We know that men take risks. Go to Google. How do men die from 18 to 25? Do you know how they die? Trauma. Men. Because we're risk takers. And then you put that on steroids. And here we are. So these are bright guys. That's how the brain functions. And then with all this, the neuroleptics and these receptors, dude, it's just freakish. And then you're firing on DHT and androgen. And again, the moral of the day is, easy as she goes. Easy as she goes. Take some testosterone, dude. Lowest dose. Dial your ABCDs in, and then go like, whoa, man, I don't ever have to get off. When I first started steroids back in my early 20s, I was so scared because I was like, I don't want to stop. I knew it. I was so irritated. I want to do a cycle. And then once you start, after 6 weeks or 12 weeks, I got to come off. Because back in the day, you come off. Back in the 80s, you come off. And we were like, holy shit, we didn't have PCT. I don't know, that crap started in the 90s or something. I don't know. Talk to Ronnie. So it's just like, I was like, oh shit, I gotta come off, white knuckle, so, and then sooner or later you do enough cycles, even a little baby dose. I did baby stuff really comparatively, and then you get shut down. This is why I don't want you guys to do it that are young. I don't want you to do it. You're going to lose your hair. You're going to get your puffy acne. If you're a looks maxer, I'm going into looks maxing. I'm looks maxing. See my jaw? I'm a looks maxing. I looks max. See, I'm having fun, guys. Looks maxing. I'm not saying it's insane, because it's an epic thing. This is what you guys are doing. You're looks maxing because you're 15, 16. I get it. I'm not putting you down because, I don't know, we had Ozzy Osbourne or so. Who knows? And regular steroids, back in the day. And we just want to do steroids. Me and this guy, he's younger than me. We just wanted to lift and, bench big. Hey, what's up, dude? And just like have a beer after, do some Skol long cut wintergreen. Copenhagen. That's just how we rolled. That's more dopamine, like nicotinic. So look, I want you guys to understand, if you're going to do it, you are going to be on testosterone. You're going to be on testosterone the rest of your life. And if you think you're not, and you do one cycle, and here's the best thing in the world. You do a cycle and it sucks. It's like the guy who's, when you're fit, do you smoke, sir? No, doc. Did you ever smoke, sir? Making my notes on my history and physical. No, doc, when I was 13, I had a few cigarettes and I coughed my lungs up. I ran home and puked and I never touched a cigarette. That's awesome. If you do steroids and you have a bad experience, I've heard it, right? I'm the research guy, right? So you never do steroids. Maybe it's a good thing. Guys like us, we do steroids. You feel good. You're done. You're finished. Next question. Modafinil.
Is modafinil an alternative to Adderall? In my clinical opinion, no. Are they both stimulants? Sure. Are they both, noradrenaline and dopamine? Yeah, you got it. Is modafinil interchangeable with Adderall or dextroamphetamine? Mixed salts is what Adderall actually is, but no, because there's extended release Adderall, modafinil not so much. Modafinil is more. You can use it off-label for ADHD. It's not FDA approved for that. However, it is, a stimulant. A stimulant is a stimulant. It will help potentially. But modafinil's more for, acute awakeness performance. Some of the guys in some special operations units in the military get it issued. They have mixed experiences with it, meaning they're in the middle of trying to concentrate on something and, they have to go urgently use the bathroom or shit their pants. So, you want to be careful with that. Is it used in the context of an alternative med for folks with sleep apnea who have, daytime sleepiness? Yeah. In my clinical practice, I have not prescribed a lot of modafinil for ADHD. It has worked well. It does hit the receptor slightly differently than, say dextroamphetamine, Adderall does. But I tend to stay away from Adderall because Adderall really causes some strong receptor downgrade, and you have to go up on the dose on Adderall. It maxes relatively quickly. If you're on instant release Adderall, there's no reason to ever go above 60. If you're with a place that's doing that, I strongly caution you to go find a new provider because there is no clinical efficacy for risk benefit that shows going above 60 milligrams a day of Adderall is worth it. In terms of modafinil, again, not something I use a ton in my practice, so I've never gone above the standard dose for that. I've used a modafinil, which, is concentrated version, the S-nomer of it, only a handful of times as well. So not a lot of experience, but no, definitely not interchangeable. Maybe if you could, follow up your statement with, where you prescribe one versus the other, do you have any experience with it? Maybe I could answer that a little bit better for you. But
is it so sleep wake? So it's really true, guys. So like law enforcement, paramedics, right? Doctors, nurses who work in hospitals. I have a pharmacist that I don't prescribe it anymore, but I was his primary care doctor, and we did, and it was legitimate because he worked all these different shifts. So, Jason, tell us about the wake cycle with the circadian rhythm with modafinil, and also, how about again? Remember, I told you about my Silicon Valley guys.
Yes. How
do they use this drug? The smart guys.
So, dopamine reuptake inhibitor, right? Wakeful promoting, right? So, when you have obstructive sleep apnea, right, that's untreated, which again, I highly, highly, highly advise you, beg you, in fact, if you fail the elbow test, if your wife, husband, partner, whoever elbows the shit out of you several times a night and says stop snoring, one, stop arguing. You don't know whether or not you're snoring because you're asleep, so knock it off. If somebody tells you you're snoring, you're snoring. You can get a home sleep study that's adequate. You can go and do it, in an inpatient setting. But if you don't treat your sleep apnea, you most likely are going to develop atrial fibrillation, and you are going to die from the complications from that. People do die from untreated sleep apnea. It is an absolute truism. There's no good reason for it.
Heart failure, right?
Yeah, absolutely, yes. It exponentially makes every cardiovascular risk you have multiply. Right. And in terms of the circadian rhythm, right, you have to have melatonin to start this to go to sleep, right? You need histamine, you need orexin, and ultimately GABA is the final off switch, right? And you regulate your circadian rhythm. The more important time in the 24-hour cycle is not when you go to bed. People get wrapped up about, I got to go to bed at the same time. I don't give a shit what time you go to bed. I care about how you go to bed, right? Because you have to turn the brain off at a certain sequence before you get to the master off switch to actually get deep sleep. But the circadian rhythm is actually set by the time that you wake up. That's the time that needs to be consistent, not the time that you go to bed. And taking in light is how we store up and then produce melatonin later on. It's taking light through the cones in the eyes. It activates M1, M2, melatonin 1, melatonin 2 production. And you're going to have that dysregulated with, specifically folks who work shift work. That's difficult. That's actually its own sleep disturbance thing. But, excessive daytime sleepiness, right? Modafinil specifically was developed for that. That's what it's, FDA approved for. It's also approved for narcolepsy, which, narcolepsy, it's kind of this thing in the medical community. It's rare to see true narcolepsy, right? But it is a real problem for these poor people who have it. They'll fall asleep at a freaking traffic light, man. They're like Sleepy from the Seven Dwarfs. They're in the middle of dinner and they're head down. I mean, it's awful, right? And there's other neurologic conditions, like specifically with the muscles in the eyes, they just shut. That's not narcolepsy. These people want to be awake. They are awake, but they can't keep their eyes open. It's a different thing. But modafinil can help. With that, I think the most prevalent trade name is Provigil, if I remember correctly.
Right. Old school Provigil.
Yep, and we can also use it off-label in depression. Again, theoretically, talk to your own provider, or if you want to be, a member of my practice, I am taking new patients. Something we could talk about would be, using, I do use stimulant medication off-label for depression because they do help with depression. Modafinil specifically, there's some efficacy in bipolar depression, as long as you're stabilizing the other pole, because the majority of the time, folks with true bipolar, 90% or greater is spent in the depressive pole. We pay a hell of a lot of attention to the other part of it because, that's where people get into trouble,
right?
With the mania part. But stimulants can also induce mania. It's one of the differential diagnoses we have is something substance induced. And, could modafinil, could Adderall, things like that are just pure stimulants, could the abuse of these drugs lead to amphetamine-induced psychoses? Yes, to the same extent that methamphetamine would. Well, no, not really. But you take enough of it, sure. You can also have cardiovascular damage. Hypertension. You could induce a heart attack. Induce a stroke or induce a dysrhythmia. If you're prone to, say, a reentry tachycardia, and you had a night of drinking, you're anesthetizing your ventricles. They're getting a little pissed off. You're throwing PVCs or preventricular complex tachycardias. Yeah, would a stimulant make that worse? Sure. They're not benign drugs. But
so what about the silicon? Let's close on this. We'll move on to the next one.
Okay.
How about Silicon Valley guys?
Yeah, so they're taking this stuff to kind of pay attention. They're also taking old school drugs like selegiline.
How about smart drug? Is this really a smart drug?
Is it gonna enhance dopamine? Yes.
No, smart. No, like intelligence. Does it? Is there any?
Well, so good question. So part of the working theory in ADHD is like, you ever sit in a bar and it's a sports bar and they got 5 or 6 games going and you're trying to watch them all and then you're trying to have a conversation. So what this drug does, when you turn up noradrenaline and norepinephrine, you tone down maybe 3 out of the 5 TVs. You still know they're there, but you're really only focusing on a couple. And now you can really concentrate on your conversation. Wow. Right. To where if you had all this background noise, but you're dialed in on something, you're like, nope, I'm watching, the Michigan State game, right? And that's all I care about. I don't care about what's going on with Indiana. I don't care about what's going on with Michigan, right? Or Ohio State, right? And all these rivalries, right? But I'm dialed in on this one. That's where something like an ADHD becomes kind of a superpower because you can hyper focus your noradrenaline and it just it magnifies things. So that's what this drug does. It amplifies that by shutting it down so that you can become hyper focused. So it is kind of like a super drive. Or remember the Underdog cartoon? He'd pop his pill and then he'd be able to grow real fast and fly and be super strong. Same concept.
But it really is potentially, a lot of guys with the edge of high driving, alpha guys and money guys. I mean, come on, this is a slippery slope.
Oh yeah.
And then they get on this stuff. I've seen a million of them, and it's just like they're doing great, and then all of a sudden they're in jail again because it stimulates some, and they get out. They end up on coke or drugs or alcohol. It's just a very fingerprint. You just gotta. And then it's just so hard, and then everything comes crashing down. But some of the really top guys that can control it, man, but they're just assholes, most of them. The narcissism, I don't want to launch off into the narcissism that's related to this, just inherently with these really top producing guys. Holy shit. And they're just all they care about. And then just brain drugs, and it's just like they want to optimize and they're on testosterone, they're on psilocybin, they're
Right.
on modafinil. I'm like, holy shit, dude. I
Yeah.
mean, it's one more. I'm like, sir, why don't you just take a freaking breather, bro? And,
Yep,
and then
for
the
sure.
whole thing comes crashing down. They have bad relationships, and again, but can it focus you if you have ADD? And can you
Yes.
turn those TVs off? What a great analogy. And then is your heart, are you hypertensive? Are your heart rate not tachycardic? If your heart rate's in the 80s on a lot of these drugs, stimulants, not to mention with caffeine and other things, and if your heart rates, I see it all the time, heart rates cranking in the upper 80s or 90s, it's normal. Bullshit, that's normal. That's horrible.
Right.
Heart rate's got to be in the mid 70s or lower. If it's not, you're in the 80s, your heart's sick.
Right.
You're sick, and you can fact check that. Again, that's the fifth vital sign. Like, what's the heart rate? Oh, my heart rate's fine. It's 84 beats per minute. Bullshit.
Right.
Something's wrong with you. Okay, next question. What do we got? Thoughts on olmesartan? Olmesartan, blood pressure medicine. A or B? I mean, A or B? Good. I could take this one, Jason. I know you know everything.
I mean, telmisartan is about the only one I really endorse. I don't know olmesartan at all.
Olmesartan, Benicar, I believe.
Benicar, okay.
Right. Olmesartan is a phenomenal drug. So I'm going to go into this real quick. Olmesartan is number 2 after telmisartan.
Okay.
Yeah.
Okay.
So it's an ARB. It's in the class of ACE and ARB. These are the RAS. These are the renin, angiotensinogen, aldosterone system blocking, old school and amazing drugs for hypertension, first line hypertension medications, ACE, ARB, right? And then we have the calcium channel blocker, the dihydropine, the non-dihydropine, and we have thiazide diuretics. Okay, that's and then we have secondary things depending on who you are, and then in that is specialized beta blockers like nebivolol that again underutilized. It's not really a beta blocker. Nebivolol is really an endothelial cardio specialized nitric oxide doning medication. When you're using a less than 10 milligrams, it got into the country on a ticket for the Fed as hypertension. But it's really much more than that. But it's unbelievably, it increases nitric oxide. So when you use this as a blood pressure medicine, it's tolerated. A lot of guys stop blood pressure medicines because they get erectile dysfunction. Okay? Yep. You could fact check that. And then who wants to take the blood pressure? I don't give a shit. Well, sir, you're going to die from a heart attack. Oh, shut up. Who cares if I die? I'm going to have sex. So it's like when you use these combinations of like olmesartan or telmisartan with nebivolol, right? Not to mention on little baby doses of amlodipine. Again, this is like a chef. I'm a chef. You have to understand the guidelines and then understand the fingerprint. And then, like Jason says, you have to fine tune it and watch people carefully with blood pressure logs. What are the effects and other aspects of what you're doing and your brain cognitive and erections? But this when I think of olmesartan, it's a great drug. It's a great drug. And it's olmesartan, candlesartan. Again, these are all AR. This is obviously my day job, right? So internal medicine, hypertension. Candlesartan and olmesartan, telmisartan, these drugs are PPAR gamma drugs, right? So apart from that, when you look for migraine prophylaxis, some of these drugs are equally as good or not better than some of the beta blockers. So especially candlesartan. I have a couple of patients that have had horrible migraine, I guess migraines or what's the tension headaches? What are the real headaches, right? Migraine, tension, cluster. Right. So this is neurology stuff. And so I'm working with them and go see a headache, a neurologist that just does headaches. That's how specialized things are. Mm-hmm. And then we work together on putting together the medicines that one stone, 3 birds. I don't want to hurt birds. I actually love birds. I'm a birder. Okay. Don't make fun of me, sir. I like birds. So, and I like to watch birds. So when you look at that one bird, one stone, and you can take care of migraine prophylaxis, you can get great blood pressure control sustainably because the erections are good. And then this is the level now of fingerprint medicine, over the course of decades. And that drug is generic. That's cheap. That's a cheap ass drug. That's been off patent. patent protection for 10 years, 15 years. So again, olmesartan is a great drug, but again, do you need an ARB like that? It can cause hyperkalemia. Here's a problem. I got to be careful with putting down the gurus too much, but when you hear the bodybuilders and some of the women dying, what they die from? They die. Forget the cardiac, chronic cardiac. They die from diuretic abuse with potassium sparing diuretics. And again, I am being gnarly on them because this is insanity. Listening to some Yahoo take spironolactone, take these combinations. Oh, you're a little genius. And then they start throwing the ARBs on board. You want to see interaction? This is a deadly interaction. If you're in a hospital and you give those two drugs together, the pharmacist is not going to. They're going to call it. You're going to page you. I mean, when I was an intern and resident, man, you sure you want to do that combination, doctor? Are you sure? No, I'm sure. I'm up my 30th hour. I want to do that. I want to do it one more time, doctor. Are you really sure? Put the nurse up. I mean, they're like, I'm not giving that. You're not doing that. Okay.
Oh yeah.
So I'm telling you, this is a wild west. And yeah, you want to come argue me? Who wants to come argue me with it? I mean, it's insanity. So you have to understand these medications from the brain up, from the chin down, of the manifestations across the spectrum when you're looking at all this physiology, from erections to tolerability to cardiac issues, and again, palpitations, hyperkalemia. You could fact check how do bodybuilders die, the women, because they're all on these crazy ass diuretic effects. They don't all die. It's amazing more don't die. It shows you how strong the human body is. But the gurus, I mean, I actually think you should arrest them. But I'm getting crazy here. I don't want to say that. I mean, because they're killing people. Okay, this has to stop. It has to stop. Someone's got to draw the line on some of this stuff sooner or later. And I don't know. You see serious damage. You see just idiocy out there. So that's what we're trying to stop. And I got an attitude. I got a mouth for it. What else we got, Mark? Any other questions?
It's a handful, but we're at 2 hours. What do you want? You want one on meth, Suboxone, or statins?
Give no. Wait. Suboxone? No. What's the other one?
Meth.
Give the meth.
Sure. Does meth raise testosterone? Why does it make your libido go through the roof? Okay, so well, I'm gonna assume this person's asking a legitimate question, and I'll try to answer legitimately, and that they didn't write this as a comedy, because does meth raise your testosterone? I'll answer that as frankly as possible. Who gives a shit? Will meth? Why does it raise your libido? Because it sends your dopamine and noradrenaline through the friggin' roof. Yeah. Number one. Number two. Okay, so it raised your libido. That's great. You'll be the coolest guy to die with a priapism, and everybody will make fun of your.
It's cocaine, right?
Yeah, it's advocating for methamphetamine use. So we talked about maxing, right? That little shithead clavicular, and yeah, I'm going to call the kid a shithead because he's advocating for children to smoke methamphetamines to get hollow looking cheekbones. Yeah. I hope somebody hollows out that kid, frankly. Advocating for methamphetamine use to raise testosterone is about as smart as, now I got to be careful. It's about as smart as swimming in a sewer and wondering why you're covered in shit.
Russian roulette, yeah.
I mean, that's just asinine. So methamphetamine, how you make methamphetamine? So one of the ingredients in that is battery acid.
Wow.
Go. I could lose weight with amphetamines. Cool.
Oh, that's
awesome.
Good.
You could lose your teeth. You can lose your hair. You can lose the functionability of your kidneys. Your heart.
One's doing math.
It increases your libido, right? Until it makes your balls fall off because you have advanced neuropathy from terrible circulation. But hey, that's cool. You'll go from being 180-pound good-looking guy and hey, I used some methamphetamine and woke me up and I did a math project. I took apart my Camaro and I banged my girlfriend for 2 hours. Good for you. 6 months later, where's the guy? Well, he's giving hand jobs down by the highway because he can't afford to buy his methamphetamine anymore, and all his teeth are falling out, and he dropped out of school and he's got nowhere to live. But yeah, hey, let's raise testosterone with methamphetamine.
We're not. Yeah.
Sorry,
No,
it's a personal pet peeve.
We're not doing
talk about
meth. We're not doing
drugs that'll kill you.
And all the dads
I mean?
out there, man, keep your kids tight, and moms, keep your kids tight. Time to be tough.
Yeah.
This is how to keep your kids tight. Drugs are out there. Only one way to do it is dads have to be dads and moms have to be moms. If you got both, you're lucky. I didn't. I just had a good mama, and it's all I needed. But there's no free lunch. It's not like the 70s. We were out there smoking some pot or something,
And I say this from the perspective of somebody, who's taking care of folks in acute amphetamine withdrawal and residency. And, there's almost literally nothing you can do. We try to sedate these folks, but it takes so much to do it. And these people, they're in agony, and the universal thing, the ones that actually make it through it, that don't have a major cardiovascular event like a stroke or a heart attack, they all say the same thing. My God, I wish somebody would have taken this serious to tell me, what the real risk of this was. I would have never touched it to begin with.
Well, it's so addictive. You can't do it. It's so addictive.
And you see kids in their mid-20s that, they've ruined their looks. They don't have dentition anymore. They have to get dentures at 24 years old.
Hopefully right. You guys got we don't want to be too much like the old timer guys, scowling down, but harm reduction. All right, guys, that's it. We're exhausted, but my brain still feels like it's going. Whew. All right, Jason, thank you so much, brother. Unbelievable.
Thank you.
Did a great night, and we had a lot of people here. We're going to do it next week. Next week, I don't want to say who's on because we're not sure yet, but we're going to have another testosteronologist. So, in the history of things here, Jason, you're the first testosteronologist to really come out.
Yeah,
Thank you so much.
Big honor. Thank you very much. I hope that it's been educational and entertaining. For folks. Because they say if you love what you do, you'll never work another day in your life. I will never work another day in my life. I love working with my patients. I love seeing people get their mental health, their physical health, their hormonal health, because all these things are intertwined, and it's awesome. And to the other providers out there, look, if you guys are on the fence, if you want to join a society to where there's camaraderie, right? There's a lot of silo practice these days. COVID drove everybody out in the middle of nowhere.
Right.
And, one of the cool things we got from COVID though, is using, these interactive, platforms that are online. We have members in the society that are from literally all over the world. Tell me another society where you could talk to a colleague, out in Chile. You could talk to a colleague in the furthest province in Canada. And at the same time, you're talking to another colleague who's down in South Africa who, is like, hey, man, look, hey, we're doing this. You got all these different systems of medicine. And then, you got providers in different parts of the U.S. like, hey, I practice at altitude. Wow. Hey, I practice in the deep South. Hey, I practice in the middle of Manhattan in the thick of things, rural New Hampshire. You got all this mix, Florida, the Sunshine State.
Jason, tell us for your telemedicine. So you're in New Hampshire.
Yep.
You see patients that will drive to you. Can you tell us about? Yep. Can you? And I know there are patients that have driven to him from Canada, so they drive from far. Okay. Yep. Now, but how about telemedicine? Can you tell us what parts of how do you work with telemedicine?
So I could. Depending on what the need of the patient is, I can see anybody anywhere. Realistically, right? I prefer somebody come and see me in person at least once per year if we're going to do hormonal management, because that's just good medicine. Even if you were on the other side of my state, I'd still insist you come in at least once per year. Labs, you can go get them wherever. It doesn't matter to me. Blood pressure monitoring, we can do that remotely. Some folks have access to, nurses. Or clinics that are local, and I can take their data, or, we can order a machine through Amazon. We can do a lot of things telemedicine wise. I'm also in the process of getting licensed in a few other states to kind of bridge that gap.
Okay.
But, with the ability to use, pharmacies that are able to distribute through all 50 states and territories, that's a big help. So, I'm of the mindset of, the telehealth platform was invented to bring access to care. And if you're not getting the care that you think that you need, if you're not happy with the level of care that you're getting, stop banging your head against the wall. You know, if you're not getting care, please come and get care. If you're afraid to get care because you think you'll be stigmatized, you won't.
Yeah.
You know, if you're you know a gym guy or gym girl, and you know you've had a primary care to sit there and clutch their pearls and oh my God, what are you doing? Please come and see one of us. We will not treat you like that. We will treat you with respect and dignity, like every patient deserves, and we will help you
New world,
either
baby.
regain your health or maintain your health. You
Right.
know, because we want you to be optimized.
Right. I fought the fight for you guys many years ago. This is not, again, we don't have to give a blessing on steroids. It's harm reduction. And a lot of people are on steroids. And if you need legitimate testosterone, that's obviously a no-brainer. There's a million clinics out there, but they're not going to be as good as the top of the game of are they certified and licensed as a testosteronologist? All right, guys. Woo! Next week, Jason, I'll see you on the next Grand Rounds meeting, brother. Thank you so much, man.
Thank
So
you.
much, guys.